Okay. Well, I'd like to thank Vivian for assisting me in presenting online, so to speak. It's a new world, and we're having to get used to participating on the internet. And I thank John Regis also for inviting me to talk about deep brain stimulation for intractable pain. Unfortunately, much of what I'll talk about is historical, because in 2013, when the Conservatives came into power, many treatments were taken off the NHS shopping list, and deep brain stimulation for intractable pain was one of them. But the price is that there'll be an increasing problem with a drug addiction, because on the other hand, in April, many drugs that were used by pain clinics have been taken off NICE approval. So the problem will only get worse, and I take this opportunity to share what experience I have in this field with all my colleagues. Now, how do you define neuropathic pain? It's been quite simplified in recent years. Pain that is caused by a lesion or disease of the somatosensory system. It is estimated to afflict as much as 7 to 8% of the general population in Europe. 5% of these patients are disabled despite medication, but as I say, medical therapy has been removed from most of our armamentarium. So new therapies are desperately needed. Now, talking about deep brain stimulation, neuropathic pain was the earliest indication, and one of the great pioneers of it was Don Richardson, working in Tulane in the United States. And he used homemade electrodes, externalized them, and tried various targets in the brain to establish that deep brain stimulation could be an established therapy. Trials were started, some time ago, and Medtronic funded 2 trials. There was the electrode 3380, which was superseded and withdrawn because of its poor design, but nevertheless, 196 patients were enrolled. 18 centers were recruited. And of the few that did come to follow-up, 46% reported persistent relief at 1 year. Then there's another trial of the 3387 electrode. That only recruited 50 patients across 11 centers. And of those that showed up, 16% showed persistent relief at 1 year. So within these 2 trials, the attrition rate was very high. 70% of the patients were lost to follow-up. But if you look at what data we have from those trials, 60% of patients with follow-up with the 3380 showed pain relief, and 50% of those with the 3887. On those basis, I'd have been more positive about giving FDA approval to deep brain stimulation, but that wasn't the case. Nevertheless, over the years, if you look at patient numbers, there have been quite a large number of patients implanted for pain, and some of them not that long ago. But none of these were randomized controlled trials, but you could see that the success rates for these patients who were wrecked by pain was not bad. So we go back to deep brain stimulation for neuropathic pain and how we do it. Well, first of all, if we take on someone for pain, we depend on very good brain imaging, first of all, a pre-op MRI, and then a CT fusion to do the surgery, to compute the trajectory. The original operation is done under local anesthesia, so patients can report whether on table they get pain relief. We use the CRW stereotactic frame, and the entry through the skull is done through a 2.5 millimeter twist drill. It was our practice to trial a patient with the electrodes externalized for a week. And if they achieved pain relief, under general anesthesia, we implanted the pacemaker, connecting it to the brain electrodes. This is what we would see on table. This is a gentleman with intractable phantom limb pain, which was beyond medical control. And here he is on table before surgery, and the slightest touch to his thumb caused pain. And then when we stimulated his sensory thalamus, you can see that his pain was totally alleviated. And this was done maybe nearly 20 years ago, and he still reports very good pain relief. If you look at historical targets, Heath described with Don Richardson the septal region. Other targets were used, the caudate nucleus, and then the periventricular gray, periaqueductal gray area, the sensory thalamus with all its subdivisions reported by Mazaz in 73. And more recently, Spooner reported a single case of stimulating the anterior cingulate cortex, which went on to become a target of great favor within the Oxford group. What do we see when we stimulate? If we stimulate the periaqueductal grade 2 to 3 millimeters lateral to the third ventricle at the level of the posterior commissure, if you stimulate at a fairly low frequency, below 20 to 30 hertz, patients report a sensation of the anatomical area being wrapped almost in a warm blanket. Or you could stimulate the sensory thalamus, and you can get a paresthesia or buzzing that would block the pain, depending on the stimulation parameters. So who do we operate on, or did operate on? We looked at patients who had neuropathic pain refractory to medical treatment for at least 2 years. And they would come to us from multidisciplinary pain teams. As far as we could, we looked for an organic cause for pain. And patients have neuropsychological evaluation to exclude any psychiatric disorders or cognitive impairment. And also, common to all of surgery, we look for contraindications for brain surgery. And then let's look at our series. Well, over the years, we assessed 197 patients. And for reasons of funding, medical contraindications, fear of surgery, psychological contraindications, 3 who did manage to get pain control medically, 87 went on to trial. 11 were explanted because they weren't happy with the pain relief, and 76 went to full implantation. Over long term, the follow-up was not complete because we did a lot of stroke patients, and a lot of them passed on as a natural attrition of their disease. And we ended up with 61 long-term outcomes. Pain assessments were the standard across pain groups throughout the world, using the McGill Pain Score, the VAS. We looked at the quality of life using a Euroqual, health surveys, and health state. Across the patients that we did get follow-up, there was an improvement that was sustained at 1 year across our group of patients, as measured by the VAS and the health state largely. And we followed them up longer term, and were able to show that efficacy of deep brain stimulation was sustained at long term, upwards of 4 years. And you can see the problem is that the etiology of the pain was quite varied: phantom limb, brachial plexus, spinal injury, post-stroke, intractable headaches, pain of unspecified origin. But yet, we could get a significant number of patients better with deep brain stimulation. And this was published some years ago. So deep brain stimulation, we would say, is efficient in alleviating neuropathic pain of various etiologies. It can be sustained long term. But the etiologies dictate the success rate. But what happens to patients with very widespread pain, but no particular anatomical target, as stereotactically defined as sensory thalamus or periventricular gray? So we looked back at the experience we had of doing cingulotomies for widespread malignant pain. And what would happen if we put electrodes in the anterior cingulate? And it's not a subject without past history. If you could do lobotomies in patients who still had pain but weren't bothered by it. And that was a finding that crossed the history of cingulotomy. And indeed, the first one was done open in Oxford in 1938 by Hugh Cairns. So we looked at targeting the effective component of chronic pain, so that although pain might still be there, it is no longer unpleasant. And so we did quite a few patients before NHS withdrew funding for widespread pain. Where do we put the electrodes? It's a standard target as previously described historically, 20 millimeters posterior to the anterior horn of the lateral ventricle. We put the electrodes a centimeter off midline and put the deepest contacts in the substance of the corpus callosum. And because we're stimulating, as we can tell, as a white matter bundle, the stimulation parameters are high: 5 volts, 130 hertz, 450 microseconds. In those days, they were all Medtronic. And we found that one could improve the visual analog scale for pain and improve their quality of life in these patients. We went on to do more until we were stopped and found that anterior cingulate stimulation is quite a potent therapy. And this outcomes are maintained over a year. This is a patient who had post-stroke pain, who had bilateral cingulate stimulation, but unfortunately at the time he had further strokes and passed on. But this is the significant statement he makes. He says, yes, he still feels pain, but he doesn't think about it. And that is the potency of this target. So what we concluded is that anterior cingulate stimulation is a good target for pain relief and improving quality of life. Selection and targeting is very essential. And we still carry on, despite the problems with the COVID and loss of it in over a year's operating, we're still doing anterior cingulate stimulation, albeit not for UK patients, but for those that come to us from abroad. There's only one randomized controlled trial of deep brain stimulation, and it's for post-stroke pain done in the Cleveland Clinic, which shows that what we found, that although the scores for pain don't improve, patients do report that they are better. And because the NHS withdrew funding, because of the multiple indications of deep brain stimulation with no subgroup that is good, we decided to and obtained funding for this trial. For want of a better name, it's clumsily called EPION, Efficacy of Pain Intervention with DBS Neuromodulation, and specifically targeted at post-stroke pain. So I've already described that, and it's what's interesting to note that in stroke, 20% of patients suffer intractable pain, and there's nothing you can do. The target of this trial is to make it very user-friendly. The pre-op workup is very similar to patients who are undergoing deep brain stimulation for funded indications, such as deep brain stimulation for Parkinson's disease or tremor or dystonia. However, the assessment is done by a clinician who doesn't know whether the patient is on stimulation or off stimulation. So at presentation, participants are randomized to off, on, off, on, or off, off, on states. And this is the pathway, very briefly. Screening to consentum, pre-op, we do the surgery. For several weeks, patients are all off to provide or prevent any microlesional benefits, and then they're randomized to the paradigm I described. Then they're crossover, and at the end of the trial, they're all turned on. The assessments are standard. So deep brain stimulation does have a future. We have to reestablish funding. We'll have to design trials, maybe different to randomized controlled trials of normal types. But what might help is that we may get, and I think we can achieve it, paresthesia-free deep brain stimulation. So we could actually do randomized controlled trials without patients telling us. That's possible. Deep brain stimulators are now rechargeable. Almost every country provides directional stimulation, so we can focus stimulation. And there is some evidence, which in the short time we have, we can't go through in any detail, but we think that there are biomarkers on recording from deep brain electrodes to make on-demand pacemakers possible for deep brain stimulation for pain. And with that, I'd like to thank you all for listening to my talk and sharing my experience with you. And hopefully trials will go multi-centered globally and we'll get the evidence we need. Thank you.